Good afternoon. Welcome everyone to ONC's Discovery Workshop on eConsent from birth to the end of life. I'm joined by my colleague Trisha Lee Roll today. The two of us will be serving as your quasi-MC for the afternoon, so we'll be hopping in and out throughout the day. And what we wanted to do is not only welcome all of you to spending this afternoon with us, but also just highlight the fact that this is an important area that we think to help advance health IT interoperability, advance many of the goals of the 21st Century Cures Act when it comes to our API provisions, et cetera. And the concept of eConsent and all the challenges associated with managing it is something that we've heard as being a challenge for many of our stakeholders for several years now. So today is what we call a discovery workshop, truly something that's intended to not necessarily provide you with all the answers, maybe highlight some areas where progress has been made and where there are some best practices currently underway and efforts to try to solve this issue in certain domains, but really bring everybody together, highlight these examples, and then talk about what work is remaining to be done. We know that eConsent can often serve as that first step in trying to get access to data, and something that is holding back sometimes organizations from providing data because they feel like they can't adequately manage the consent process. So again, throughout this afternoon today, it is a workshop, and we're hoping that you'll be able to roll up your sleeves. We've got a lot of subject matter experts who are going to give us a lot of their time today. And we want to make sure that all of you in the audience has a chance to use the chat, to have some peer-to-peer interaction, get engaged in the breakout sessions that we have, hopefully learn a little something throughout the day, and then use this event as kind of a jumping off point to figuring out how to solve the remaining challenges and problems we have to make eConsent something that is not a challenge going forward. So with that, I would also like to recognize the fact that this has been a long time coming. We spent over the past year really planning this event. We took our time with it to make sure we got it right. We engaged with several stakeholders, across, payers, providers, patient advocates, et cetera, physicians, clinicians, interoperability, consultants, et cetera, standards organizations, to try to really figure out, what were the remaining issues and how do we kind of solve this. One other unique aspect is if you notice in the title, that it is focusing on a coverage from birth to the end of life. So we know that eConsent can often look different depending at what stage in life a physician or a patient that they're dealing with is in. So we know that sometimes there will be nuances that'll need to take into consideration, but also, as everything with ONC, we are trying to look at kind of what is that common core infrastructure, common approach that could support this entire journey, and then when necessary, add on to that those specific nuanced areas. So with that, I'm going to turn it over to my colleague Trisha Lee, who will walk us through a little bit of logistics for the day.
All right, so what can you expect from this workshop today? Next slide, please. First and foremost, we really have a vision of really hearing from you. We have set up and structured this day to include time, not just to hear from experts, but also for you to participate in some really creative and hopefully fun for you breakout sessions. As Stefan mentioned, we want to think about how we can let equity by design and health equity kind of be a guiding principle. We don't want to just think about eConsent and how it works for just one set of people, but thinking about the fact that we all might need to consent in different ways, depending on where we are at different life stages. We want that to kind of be a kind of principle that we weave into our discussion today. And so when you registered, you noticed that you selected certain breakout rooms by stage of life. We're going to talk about how eConsent can work for individuals and their proxies. Additionally, we want to really focus our time on the technology that enables this to happen. You're going to notice that we're going to talk a lot about the standards, the workflows, the enabling factors to really operationalize eConsent workflows. We're going to acknowledge the fact that we're not all doing this the same way. There might be folks that have some workarounds or some kind of quasi solutions, but that's okay. We want to hear everyone's perspective on this because we recognize that while we're all working really hard at this, there's probably a shared goal that we all have, right? And that is, while we might not all be doing this fully electronically, how do we get there? And so we're going to start off by talking about some policy. talking about some of the regulatory landscape that affects all of this, because we want to kind of get that out of the way. We don't want to spend the rest of the day going back and forth on some of the regulatory hurdles, but we want to talk about it so we can then be in a space where we can imagine that we had a regulatory framework all worked out, or imagine that you know and understand all the nuance of your state laws, and imagine that policy is not the issue. How do we operationally implement solutions to get this done? And so we're going to start off with our Chief Privacy Officer kind of walking us through that policy and regulatory landscape, just to get that out of the way, to free us up to really talk about the nuts and bolts. We'll then have a discussion and a presentation around the standards, and then we'll continue throughout today's agenda. So just to remind you, we're going to start off talking about the regulatory landscape, but we really want the meat of the rest of this workshop to really focus on how do we get past that and actually do the things. So with that, let me hand over to our Chief Privacy Officer, Catherine Marchesini, who will present our policy and regulatory overview.
Thanks, Cicely and Stefan. As mentioned, I'm Catherine Marchesini, the Chief Privacy Officer at ONC within the U.S. Department of Health and Human Services. I'll spend a little time this morning, as Cicely mentioned, or I should say evening or afternoon, wherever you're joining us from, to share a little bit about health information privacy, particularly at the intersection of consent and information sharing. Before diving in, I want to make note that the information contained in this presentation is based on the provisions contained in the relevant statute and regulations. While every effort has been made to ensure accuracy, this presentation is not a legal document. Please note that other federal, state, and local laws may apply. Examples are merely illustrative and may be simplified for ease of discussion, and this communication is produced and disseminated at U.S. taxpayer dollars expense. Before I dive in on some of the specifics of the legal and policy landscape, I want to touch briefly on some contextual kind of areas just to level set a little bit, as well as then jumping into the actual laws, and then maybe just closing out a little bit on some of the focus areas that Tricia mentioned. So before talking about some of the specifics of consent, authorization, things of that nature, I thought it was helpful to have just a very loose conversation about consent, the term. It's often used interchangeably with very other uses of terms. You can see here on the slide, permission, authorization, approval. But at the end of the day, what we're here to talk about today is really looking at when a patient is asked about sharing, disclosing, releasing control, if you will, of the information that may be in the hands of the person who is asking the question. There's a lot of ways that this can be technically represented or expressed, and there's a lot of detail that may need to be captured depending on the type of information that's exchanged, the purpose of the exchange, and the recipient of that exchange. The other kind of overarching background information has to do with, I would say, a bird's eye view of looking at the landscape. So you'll see here some layers. Overarching being the HIPAA privacy rule, given that that is a rule that is most folks are familiar with in healthcare, and that's one of the leading areas that kind of touches on health information sharing. And then there's other federal laws and regulations that kind of overlay that. And then comes in state law and then organizational policies. You'll see here some high level points, kind of where HIPAA lands and intersecting with other federal laws. And I'll touch a little bit on this on the later slides, but just thought it was helpful just to be clear, when we're talking about sharing identifiable health information for treatment payment healthcare operation, HIPAA does not require consent to be collected. However, HIPAA allows for consent to be collected. When it comes to other federal laws, there may be out there, that's often where the consent requirement comes in at the federal level, and then similarly at the state level, depending on types of information, organizations that are being collected, organizations that's collecting the information, and then organizational requirements that speak to that. So I thought it was helpful, we talked about the consent term, kind of the overarching overlay of the various laws, I'd say the categories. We can start with HIPAA. Again, who must comply? I imagine a lot of participants that are joining us today are familiar, but for those that are not, This is just a really easy way to look at, who HIPAA covers, covered entities. You'll see on the slide examples of those, as well as business associates. And the reason why this is important, because a lot of the conversation today will talk about information that is in the hands of a covered entity or someone that is covered by HIPAA. With that being said, this is just a snapshot of, HIPAA, if you had to show it on a slide, who must comply. Really, for purpose of the conversation, as mentioned, we're assuming that a lot of the personas today and the use cases, folks are covered by HIPAA. What, information, once you're covered by HIPAA, do you have to protect, or, when the consent requirement comes to play, what information are we talking about? Protected health information. You'll also hear about electronic protected health information, and then as well as electronic health information. But generally speaking, wanted to share this from a HIPAA perspective, and then how it must be protected. And that's often where the term consent comes to play, but just understand consent is not really used in the actual HIPAA regulation. It's a term that's used interchangeable with other legal kind of terms under the HIPAA umbrella. With all that being said, I wanted to make note that the HIPAA privacy rule really talks about uses and disclosures. So there's an overarching principle, and just, I guess, if you remember two things today, one being, a covered entity or a business associate, they're only able to share information as the privacy rule permits it, or when the individual gives written authorization. And so this is when consent is often used. And there's only kind of two categories in which required sharing happens. You'll see that listed. And then you'll also understand that all other situations, it's permitted. And that has to do with some of the talks today. Lastly, covered entities can provide greater protection. So this is often where the organizational policies come into play. Just to highlight some of the areas under HIPAA where express permission is not required. So this means where HIPAA does not require consent, it's optional. You'll see here listed on the slide some of the areas I touched on: treatment, payment, healthcare operations. There's some situations around medical research, and then actually to the individual personal representative. And we'll talk a little bit about that later. The other thing I wanted to highlight is HIPAA provides for an individual's right to request a restriction on the uses and disclosures of information. Again, consent is not used in HIPAA, but I know often in industry, some of these terms are used interchangeably. So I thought it was important to highlight here. I'll kind of transition into where HIPAA does require what is called an individual authorization, but consent can be used for today's discussion. Again, you'll see some items listed here. What you can view on the slide, marketing, sale of PHI, psychotherapy notes, but just understand psychotherapy notes has a very specific meaning under HIPAA, some medical research, and then, the purpose is not specified. And for example, if you're trying to share it with a third party, example here, drug test results for an employer. I also wanted to touch on student immunizations. While it doesn't require an individual authorization as HIPAA uses the term, there is a requirement that there has to be agreement from the parent or the guardian or the student in the case when there may be an emancipated minor, for example. Now I know I ran through HIPAA given time. I did want to just touch on the right of access. Again, the purpose of today is about consent. Some often may see that, when an individual requests access to their own information, they may use the term consent, but for HIPAA purposes, it's a right to request, but understanding from a technology standpoint, it could be represented similarly. But wanted to make note that there is not a requirement when an individual requests it for themselves to get it in writing. A covered entity may require it to be in writing, but that is not a requirement under HIPAA. Also, just to touch on personal representatives, sometimes proxy, the term proxy is used for HIPAA purposes. A person, there's a definition, and just understand that a person is legally authorized to make a healthcare decision about an individual. So it has a very specific meaning, but for HIPAA purposes, an individual and a personal representative is often, used interchangeably, and that the rights would be the same. So ran through HIPAA, we'll touch a little bit on information blocking, given that we are ONC and the regulations, but overall, the information blocking regulations operate in a manner that does not conflict with HIPAA, and it does not require disclosures of electronic health information in any way that would not be already permitted under HIPAA. What to point out is, if it is permitted, or if an actor is permitted to provide this information, there may be a privacy exception or additional consent requirements that an organization may need to meet, but just wanted to make note of that as well. Lastly, the EHI definition. I know the term is used, and that's where the information blocking rule defines what EHI is, but generally speaking, it's the same as electronic protected health information under HIPAA that would be in a designated record set. I know that's part of today's discussion. I know we're running short on time, so I got to breeze through this quickly. In addition to HIPAA and the intersection of information blocking, you'll see here on the slide, there's other federal and state privacy laws or disclosure laws that may apply to an organization. A lot of it is centered around categories that are traditionally perceived as being sensitive information, and just know that there are additional consent requirements, or I should say initial consent requirements that may apply before disclosing. Similarly, you'll see here about state laws that may be in place, and these laws still apply and exist even when HIPAA is there. Again, a lot of it is around mental health, HIV, sensitive information areas. Something to consider, when you're thinking about today. Again, I know the focus is not on policy, but when you're trying to think through, does a law apply or a policy apply? Who's holding the data? What type of information is trying to be disclosed to whom and for what purposes? Lastly, I've just 2 slides left. Thought this was a good way just to end, given this is where we started, just as a snapshot of really just trying to see what HIPAA requires, what other federal laws may require against the backdrop of state law and policies, but understand that consent can be collected through various means. And then lastly, as Trisha Lisa mentioned, there's a lot of conversation, and we understand that the intersection of laws and state variability, as well as different use cases that all of you are facing with. We really hope that today's focus will really look at how technology could support capturing a patient's choice, consent, permission when dealing with the exchange of health information electronically, and trying to maybe think about it agnostic of the use case that you come to it from, or not necessarily focus on why it's required. It could be a law, it could be an organization. It also could just be that a patient wants to make the choice. And so with that, thank you for joining us. I know there's a lot of time that it will be taken from your day, so really appreciate you spending the afternoon with us. With that, I'll stop sharing and turn it back over to our host and hostess.
Thank you so much, Catherine, for that great presentation. And I know it's not an easy task to try to summarize all that information, especially once you get into the area of the state. So I really appreciate you putting that together for everyone. And then if you notice in the chat, a lot of people were eager to get copies of that presentation. And so for everyone's knowledge, if you haven't been following the chat, if you're only on the audio, yes, the slides and the recordings from today's event will all be posted online following the event. Stay tuned. So next, we're a little bit ahead of schedule, which is great. It's always nice to do that. We can work in some breaks potentially at some times. But next, now that we've gotten the legalese out of the way and all the legal disclaimers to make sure we're in the right place and right frame of mind, we kind of put that behind us, or at least keep it in the back of our mind as we do the rest of the work today. Upcoming next, we've got Pooja Babra from Point of Care Partners, who's going to take on also probably, maybe not as equal, but also a very difficult task of explaining kind of what are the current state of standards for eConsent today. What's new to enable the capture, maintenance, and sharing of an individual's consent decision. So with that, Pooja, I hope you're ready since we're a few minutes ahead of schedule here, but I'm going to turn it over to you to walk us through the next set of slides to bring everybody up to speed on what types of various standards related activities are going on around managing consent. So Pooja?
Great. Thank you so much. Can you hear me okay? Just want to make sure you guys can hear me. All right, I'm seeing nodding heads, so fantastic. So good morning, good afternoon for those on the East Coast. My name is Pooja Babra. I'm actually a practice lead for Pointy Care Partners. We are a health IT management consulting firm. I'm going to spend, as Stefan said, the next kind of 20 minutes or so doing a quick overview of just current standards and some industry work that's happening today related to eConsent. So we at Pointy Care Partners started working in this space probably about 2 years ago now with a client and have expanded some of our work. And I have to tell you, it's funny because I always say that eConsent's a very complex topic. And I always get funny looks when I say that because vendors and others will come up to me and they'll just be like, no, it's pretty simple. We just capture the patient's consent and we share that. But I think as we go throughout today, you're going to find that, that's not really the case. It's not that simple. And you'll see how truly complex this topic can be, which is why I'm really excited to, have this day as this listening session. So let's go to the next slide. So I just want to spend a quick minute just talking about the 4 types of consent in healthcare. We've got 4 types: the privacy, medical treatment, research, for example, clinical trials, and then consent for instructions for end of life. I think Catherine kind of mentioned, we're not really going to be focusing on medical treatment per se, but, really kind of around these other areas, which include privacy, the research, and then, of course, one of the breakout sessions is around end of life. But, from a historical perspective, really up until a few years ago, the way we captured consent was very manual. And it's still today in so many cases. I mean, we all go to the doctor, we fill out the paperwork, we sign the consent forms, and it's really just kind of the main method of capturing patient consent is manual today. Or if you did capture consent electronically, there wasn't necessarily an easy way to share it with others. But one area, actually clinical trials, kind of really led the industry in terms of kind of the ability to capture a patient's consent electronically. Let's move to the next slide and we'll take a kind of look at historically. So, kind of originally, the original kind of dabbling, I would say, in eConsent was around clinical trials. That was really the first area that we started to see electronic consent being captured. And, as we moved over the past few years through industry initiatives, regulation, and even ONC funding, we've really started to drive forward the capturing and sharing of electronic consent, especially around patient records. With the 21st Century Cures Act, the information blocking rule, and even, the updated SAMHSA 42 CFR Part 2 rule, which has to do with substance abuse and mental health, there's this real need to be able to capture and share a patient's consent electronically. But once you start to think about that, there's also kind of a lot of unanswered questions that come around that that still need to be resolved. Some of those include legal questions, some technical questions, which is, probably a lot of what we're going to be talking about today. But there's also ethical questions when it comes to sharing certain types of data. And later today, we're going to hear from some panelists who actually have, they're going to share their lived experiences around this. Including how to revoke consent once you've decided to share your information with someone. And finally, what's interesting, with the final rules that dropped, it is mandatory for payers and providers to share data, but, it's interesting, we see in the work that we do that they still see it as a huge risk. And so there's clearly a lot of hurdles for us as an industry to overcome to make sure that we're addressing concerns and building these models and frameworks of how we're going to share information. So today's listening session is really a place for, as Stefan and Tricia Lee mentioned at the very beginning, to share thoughts on frameworks, models, even best practices that we've seen and have in place today, especially as it relates to EHI, their electronic health information that is mandatory to be shared today. So I'm going to take a dive into some of the current standards. So let's go to the next slide. And you can go past this one. Thank you. So when we talk about current standards related to consent, really the main standard we have today, or the main focus, is on the HL7 fire consent resource. This covers privacy, medical treatment, and research. And I know HL7 is also working on a fourth use case, which is advanced directives. The HL7 fire resource is really scoped to cover all three use cases and the additional one, but the privacy use case is the one that's fully modeled at this time. I also do quite a bit of work over at NCPDP, the National Council for Prescription Drug Programs. That's the standards organization that's focused on pharmacy standards. And I know as they were looking kind of across the industry to, figure out how to share consent for specialty prescriptions, they are also going to be utilizing the fire consent resource for that specialty enrollment transaction. So lots of different use cases that can be used and modeled and implemented. And I'm seeing in the chat that there's also some other resources and standards out there today. So I'm sure during our breakout sessions, we'll be diving into those as well. So thank you for those notes. So let's move to the next slide. So when we talk about eConsent, there's also kind of these peripheral concepts around areas that we need to focus on and where there's standards work being done. And I want to briefly touch on each one of these. Identity management and trust frameworks. So when you think about sharing records, you need to know that, the person or the record that you're going to share belongs to the patient, and you need to trust that the records you're sharing is being received, or the receivers need to understand and have that trust that record belongs to the right patient. So there is some standards work being done in this area, and I did want to call out the fact that in the most recent Appropriations Act, it actually includes language that's going to allow ONC to work with industry to develop some patient matching standards. If you follow this at all, this is pretty big because for many years, there's actually been a ban on any kind of work around this, even just to do the research around kind of best practices. So we're really hoping that this language stays in and this gets passed. So it'll open up some funds to be able to start working on this. NCPDP, I talked about this organization a little bit earlier, but they also have what they call Universal Patient ID. That's an ID that's actually attached to a patient's record, really on the back end of pharmacy systems. No caregiver, no patient would ever actually see this, but it has been incorporated into the NCPDP standards and allows for more accurate identification of patient records. And of course, we know there's a lot of work being done around with TEFCA around trusted frameworks. So, this identity management, trusted frameworks, when we talk about consent and eConsent, that's definitely something that we need to be thinking about and talking about as well. So the other topic related to eConsent is really this digital identity. This covers the ability for a patient to have really a kind of a digital credential when they're accessing their records. This could be also leveraged with eConsent and identity management and trust frameworks. I liken this to kind of the electronic prescribing of controlled substance prescriptions and things prescribers have to do. So they have to get this NIST level 3 digital identity proof, which allows them to sign and send an electronic prescription within a trusted framework. And I know there's some efforts going on today at the Karen Alliance, one of the HL7 accelerators, that is very similar to this work that would allow a patient to get a digital credential and allow them to sign into patient portals, apps, and other entities that adopt this credential. So I know there's a pilot program going on with that. I think Ryan Howells from the Karen Alliance is going to be on a panel later today. So I'm sure you'll hear more about this work. And then also the Linux Foundation is another one. They host this Decentralized Identity Foundation and Trust Over IP Foundation, which are both doing work in this area. And I know Jim St. Clair is also, I think, going to be on a panel later today. So just so everyone knows, it's hard to kind of hit all the initiatives. So we were trying to get a sampling for everyone, but throughout the day, there's going to be opportunities to share what folks are doing around all this as well. So another area we need to think about when we talk about eConsent is data tagging. I think a lot of people think that this really comes into play when we're just talking about sensitive data, such as substance abuse, and that's where that guidance, from SAMHSA, CFR Part 2 comes in. They really point to current EHR functionality for data tagging. But I would argue now that we've given patients the ability to share their records without, entities outside of HIPAA-covered entities, consumer apps, and even organizations outside of healthcare, this concept of data tagging becomes even more important. So another eConsent related topic that we need to be thinking about. Audit trails, those have been around since EHR's, certification and all of that. And so, being able to keep, retrieve, access what has happened with patient's record and who has shared it and who has accessed it and, who's made changes continues to be very important in the context of eConsent. And then finally, just data exchange beyond healthcare entities. Stewards of Change, I know Daniel Stein has been on and he's been running a group, Project Unify, which talks about all the ways we're having to share data outside of healthcare entities. And you'll be hearing from a couple of folks later today as well involved with that project as well. So as I mentioned, as I started this session, eConsent can be very complicated, especially as we start to think about it in the context of interoperability. And, as you add on these kind of peripheral topics, you can see, how extremely complicated this topic can become. So let's go ahead and move on to the next slide. What I want to just briefly touch on now is just some industry work that's being done around consent. So we can move to the next slide. So again, this is just a high-level sampling of some work that's being done. I've touched on a couple of these already, so I'm just going to briefly touch on one or two of these. ONC had a LEAP grant a few years ago that focused on eConsent work, and there was actually work done at the San Diego HIE where they focused on standardization and implementation of a scalable patient consent service based on the FHIR consent resource. I know there's a couple organizations listed on this, Interoperability Institute. They've actually taken this open source code and brought it into what they call their interop community and their MELD platform. They allow vendors to actually access the code and test using synthetic data. And I know we've got a couple of organization and vendors on later today who are also going to be talking about this, taking that open source code and what they've done with it as well. And then the only other one I want to mention on this slide is BPM Plus. If you're not familiar with that organization, they actually sit under the Object Management Group, and they're focused on developing business processes focused on healthcare workflows. Some of the very early work that we did as point-of-care partners in consent was focused on advanced care planning. And we took some of that workflow information, shared it with BPM Plus, who then turned it into an automated business process, which focuses on the ability for stakeholders to access a patient's advanced care document at the point of care. So if you're attending the end of life breakout group, I'm sure there'll be some discussion on that as well. So great work being done in the industry. Let's go to the next slide. And I want to briefly touch on some other work that's recently been done. I mentioned Stewards of Change earlier. There was a white paper that was released by Stewards of Change, part of the National and actually the National Interoperability Collaborative, or NIC. And this white paper really focused on what needs to be done to modernize consent to advance health equity. You heard Tricia Lee mention that at the very beginning, how important that is. And there were a lot of industry experts. We had point of care partners along with industry experts contributed to this white paper. It's really a comprehensive view of the market. And just to highlight this report briefly, it was meant to show kind of the current state of consent. I think the last time a market scan was done was over a decade ago, so a lot of things have changed. But it really highlighted some concerns, including the fact that we really have some antiquated consent processes. We've got information spread across all these different systems that just really aren't easily accessible. But it also highlighted the difficulty of sharing information across sectors and the impact that has on health equity. So if anyone's interested in reading this report, I highly recommend it. Let's go to the next slide. I'm not going to spend a lot of time on this slide, but because you're going to be getting a copy of these are really some quotes that I pulled out of the report. And the one thing I want to highlight here, and as I mentioned, we heard Tricia Lee mention it. We keep hearing Mickey Tripathi mention it, and everything that he talks about is this equity by design. So anything we do around eConsent, we really need to take into consideration health equity and equity by design and the impact it has on the entire population. So let's go to the next slide. So finally, I just wanted to briefly touch on some work that we had done at Point of Care Partners. This again was some of the early work that we did around eConsent. In addition to the workflow that I mentioned that BPM Plus was able to use, we started to look at some best practices around eConsent. Not going to go into a lot of detail here, but I just want, again, to kind of keep these models in the back of your mind as you go throughout the day. So in our research, we actually found 3 models which stood out to us in terms of kind of best practices around capturing consent. And these are the patient-centered consent model, the patient-to-many approach, and the shared decision-making model. So just briefly, the patient-centered model is essentially giving patients access to like a portal, that's connected across their personal enterprise, or kind of a personal EHR that they would have. And the patient's able to set up a care team who they choose which documents or types of documents they wish to share with their care team. So it really puts the decision making in the hands of the patient. The patient-to-many approach is very similar, but in this model, the patient actually gives consent to organizations or teams of physicians versus individual providers. So if you're getting your care within a health system, or a provider organization that has many specialists, you can provide consent more at that organizational level, or teams of physicians, which is another approach to do. And finally, there's this concept of shared decision-making model. We had done a study around this, or there was a study done that we reviewed. It was interesting. It actually involved HIEs. In the study that was conducted using consent materials, and only about, I think it was 70% of patients had a moderate idea of what they were actually consenting to, which kind of led to this work being done by the AMA and others saying that, it's really, important for organizations and physicians themselves to make sure that patients understand what they're consenting to. And again, I go back to this idea of equity by design. If a patient's not even understanding what data they're sharing, who they're sharing with, and you'll hear, I know later on during the day that, some people aren't willing to share their data because they have a lot of concerns about, who's going to see their data. And so they may not even be accessing the care that they should be getting because of that. So let's go on to the next slide. I think this is actually my final slide. So just wanted to quickly touch on this one. Out of the work that we've done with our clients, with other organizations, just kind of looking across the industry, this is kind of the use cases that we as point of care partners had identified as potential areas of focus. So it was great as we were, as chatting with the ONC team about this workshop. And I think it really comes down to the fact that eConsent's really complicated. And I remember kind of in the early days talking to people, and it's really hard for you folks sometimes to wrap your heads around what's needed kind of in a practical sense, right? As we start to focus on this. And I think it makes a lot of sense to kind of focus on the different use cases, because then you can really dive in to understand, the workflows, the data that needs to be exchanged, the entities that are involved, and really think about, how is this going to work in real life? How are we going to make sure that the patients are understanding, working through the legal, technical, ethical questions that we have out there. So we identified, 4 use cases, which we're starting to dig into with some of our clients and some industry work. And, we're thrilled to see that these really align with the ONC ones as well, including the maternal and infant health, the early medical intervention and education, the social services, which I mentioned you're going to hear about, and end of life or the advanced care planning. So I think with that, I will turn it back to Stefan and just want to say thank you. Hopefully I was able to cover that. It was a lot. And like I said, I know there's a lot of initiatives out there. So thank you to the folks that are adding into the chat some of the additional things that we weren't able to get to in this time.
Pooja, thank you. That was amazing. Really appreciate it. I know it's a difficult task to try to summarize all the various activities going on, but I think you did a great job and certainly provided some people with additional context around the differences in some of these initiatives. Also, I want to thank you for acknowledging the fact that a little bit later in the afternoon, starting around 3 o'clock Eastern, we're scheduled to actually dive in a little deeper on some of these initiatives. So many of the things that were talked about, you'll have a chance to learn a little bit more in the various breakout rooms, the second set of breakouts around 3 o'clock. Also, before we get to the next session on this, I wanted to call out, as Pooja mentioned, the chat. The chat has been on fire. And not FHIR, but actually FIRE, and really appreciate all the engagement there. So thank you for answering the call, for everyone figuring out ways to leverage the chat to be engaged with some peer-to-peer communication. There is a plethora of links to different resources and initiatives that have been highlighted in there. I appreciate, Julie Moss, Kenneth Berkowitz, Eric John, Ryan Howells, John Merkey, Hannah, so many others who have been providing, again, just tons of resources and links. Mohammed, Jim St. Clair, Amol, really appreciate all the additional resources. So we're definitely going to be archiving this chat and figuring out how to kind of, share that also as a posted document as a resource, but highly encourage people to visit that now. And if you are only on the audio line, recommend you find a place, pull over your car if you have to, try to get on a good hotspot and join through the visuals as well. All right, with that, I'm now going to turn it over to my colleague, Trisha Lee, to introduce the next panel. Trisha Lee.
All right, thank you so much. So we've heard a little bit from Catherine about the regulatory landscape and how you think about eConsent. We can do it. So let's not let the policy, the regulations, and the regulatory framework be a roadblock, but let us think about what's possible when there is a path forward. We thank Pooja for helping to walk us through a sampling of some of the standards and initiatives that are out there, thinking about how to operationally make this happen. But now we want to talk about how we can actually do this in a way that works for all people. And so our next panel is called Equity by Design, Making eConsent Work for All People at all stages of life. We're super excited because our Chief Medical Officer, Dr. Thomas Mason, will be moderating this session, and he will be joined by a wonderful panel of experts, Carol Robinson, Nancy Lush, Ed Daniels, Tanisha Harrell. And we are really, really, really appreciative of having you guys here. I'll stop talking because we want to give as much time as possible to you. We're right on schedule, so you have until 1:30, and I really hope that everyone is listening for this session because it's going to be spectacular.
Completely agree, Trisha Lee, and thanks so much for that introduction. As Trisha Lee mentioned, my name is Dr. Thomas Mason. I'm the Chief Medical Officer of ONC, where I work closely with the broader clinical community to provide clinical input and perspectives to our policy and technical activities at ONC. Prior to joining ONC, I worked in the public safety net system in Chicago, working with underserved communities on the South Side as a primary care physician. I was also a medical director of a public health intervention that was focused on addressing healthcare disparities, achieving health equity by building trust with communities and addressing social determinants of health and social needs. And I've brought that background and expertise to ONC, and really excited about an initiative that we're working on that Pooja mentioned as well, called Equity by Design. And we're really looking closely at how do we, from an ONC perspective, leverage our authorities to make sure that health equity is a core principle in the design, build, and implementation of health IT systems across the country. And we've done a number of listening sessions, hearings, focus groups, and one important theme that continues to come up is the importance of data collection, and consent is such an important part of that process. And so I'm really excited to moderate today's panel, which is focused on how can eConsent workflows be designed to work for all people to ensure that health equity is a part of that workflow as well. We're going to dive into what does an ideal eConsent solution look like from a consumer perspective. And as Trisha Lee mentioned, we have a wonderful panel of experts, and I'm really looking forward to the discussion. And what we will do to start is I'll ask each panelist to just state your name, organization, and role. And then after we've gone through introductions, we can jump into the questions. So let's see here. Why don't we start with Carol?
Sure. Thanks so much, Dr. Mason. Pleasure to be here. My name is Carol Robinson. I'm founder and CEO of two companies, Cedar Bridge Group Consulting, a 9.5-year-old consulting firm based in Portland, Oregon, focused on health policy and the intersections with health information technology, and a new digital health startup that we call Medado Health. Medado is a little takeoff on My Data, and Medado is focused on consent management and digital forms management. So thank you for having me.
Thanks, Carol. And Nancy, it looks like you're next.
Well, yes, I'm Nancy, CEO of Patient-Centric Solutions, and our mission is to enable patients and providers to easily exchange data across facilities and so that accurate clinical data is always available when needed to inform care. So we were a very early FHIR adopter and basically an advocate for many of the benefits of FHIR-based interoperability. We offer a patient-mediated exchange solution, which is based on a computable consent, which is patient-generated consent supporting granular data exchange. Thank you.
Thanks, Nancy. I think it looks like Ed's next on my screen. I think you're still on mute, Ed.
Let's try that. How about now?
We can hear you.
All right, good. My name's Ed Daniels. I'm a health IT consultant with Point of Care Partners. I work in a lot of different areas, including health information exchange. And also I've done a fair amount of work recently in the area of eConsent. And but today, actually, once we get rolling in the panel, I'll be talking about my experience with emergency medical services and some work that I did in that area. Thank you.
Thanks so much, Ed. And Tanisha?
Good morning, everyone, or good afternoon. I'm on the West Coast. My name is Tanisha Harrell. I am the Director of Partner Engagement with 211 San Diego and the Community Information Exchange. And I primarily work with onboarding and bringing on new partners to participate in our platform. Thank you.
Excellent. Thank you so much for those intros. And I know during the prep call we had, we were really crunched on time in terms of, trying to limit. So it looks like we've got 5 extra minutes. So I think, we can use those 5 minutes to add on to some of the great perspectives and conversation we had on the pre-call. But the first question I'd like to ask each panelist is, we would love to hear your perspectives on how we can make eConsent solutions work for everyone. And I say we just go in the same order as the introductions, if that works for everyone.
Well, sure, absolutely. So how we can make eConsent work for everyone is basically putting things more in the hands of individuals. And that's tough right now. Cedar Bridge Group entered into the Move Health Data Forward Challenge way back in about this time in 2016, where the HEART standards were used to do some patient-mediated data exchange. And we experimented with different consent models and ended up getting to the finals with a direct message form of eConsent. And it worked pretty well, but it wouldn't scale. And I think that's the real key here, is making consent work for everyone means that consent needs to scale across a community. There needs to be a federated model with a centralized registry, like a public utility of sorts, where that resource, that consent form or forms, are available at the right time, the right place, and the right purpose. And that individuals can revoke consent if they've given consent in the past, can consent for part of their information to be shared, or consent for the purpose or the time frame. And these are all, kinds of granularity that are super important to make health equity actually be realized. Because if we insist on all in or all out in terms of consent for data sharing or data use, and we haven't really talked about the monetization of data yet in terms of this meeting, but it's something to definitely think about. Individuals feel more valued when they have choice. And this is really the important piece. So I'll stop there and let my colleagues and other panelists speak. Thank you.
Thanks, Carol.
Thanks, Carol. You have very, very great points, and I think I'll just add on to those. So when I thought about my key points, patients and consumers need to have consent systems that they can trust and which are easy to use. Providers need systems also that can be automated to both protect privacy and eliminate burden. So that is really not the situation of healthcare, the environment today. So I thought about, what are the key goals for eConsent? So ease of use, certainly, but also ease of access. So we need to make it easy for patients to manage all of their health data sharing preferences in one place. We need to support granularity, as Carol pointed out, and this refers to the ability for the patient to specify which aspects of the health data they agree to share and which they don't wish to share. Consents need to be computable to both reduce burden and expedite exchange. So this means that computer systems need to be able to interpret and enforce them. We need to support transparency. So patients should have access to both a summary of all of their existing consents, and then they also need to know when someone has accessed the data and what part of their data they've accessed and when. They all need to be privacy respecting so that only the data specifically authorized would be shared. The tagline is "No data about me without me." And then we need to have privacy notices that are easily understood. So I'm going to go and kind of make a couple of technical suggestions without trying to get too technical. So the first point is that the consent to share data is a unique case and requires specific standards to really do that job right. So when we combine those with other use cases, key issues sometimes become commingled and conflated. So consent to share data should be treated really uniquely from other types of consents. Point B, and I appreciate all the call outs to the Conterra organization, but user managed access, or UMA, in conjunction with high level trusted authentication and consent receipt standards provide solutions to meet many of our technical challenges today. Each of these should be really part of our eConsent data fabric. And then point C, I think we should have a standardized API, much to what you were referring to, Carol. So the consent itself can contain PHI, and so that must also be protected. For instance, if a patient's consent indicated they didn't want to share their mental health conditions, and then they shared that in a consent, and the recipient saw that consent, you would effectively be sharing that piece of confidential information, which they wish to keep private. So if we had a standardized consent API that could be made available, instead of actually sharing the consent content themselves, that PHI would be protected, so that the API would actually protect the PHI within that contained consent. Anyway, we can talk a little bit more about that later. And then finally, many users will not understand the nuances of implementation that protect security and privacy. So we shouldn't be trying to explain all those details to users, but instead give users a dependable way to trust that it's being handled properly. So as an example, all consumers don't need to understand all the details of how a car works in order to be able to trust that that car is going to get them from one place to another. Nor do they need to understand all the nuances of a banking system in order to deposit money in a bank. So healthcare will need a trusted seal that eConsent systems meet certain criteria. It does not need to be government approved necessarily, but does need to be some sort of certification that users will trust. And then all of this needs to be wrapped in a patient-friendly solution that will make it easy for patients to use across the healthcare journey. And I know we're going to be hearing a lot about that in all the other sessions today. So thank you.
Thanks so much, Nancy.
Thanks, Nancy. I think your point about trust is really important. And, you know, throughout my career, I've mostly been focused on efficiency, developing efficient automated systems. And usually that means taking the person to the extent possible out of the loop. But as we know, in consent, we're talking about a person agreeing to a medical procedure, agreeing to share their very private data and things about their lives. And I think we need to remember not only that that takes a lot for a person to trust the system enough to do that, but also that we're talking about situations where it's various populations that have had maybe not the best experience with the healthcare system. And so they really, in a way, you could say the healthcare system hasn't earned their trust. And now yet we're asking them to interact with an automated system and share the most private things about their lives. And, you know, even though it might be certified, as you're suggesting, Nancy, it doesn't mean that they're going to automatically trust that that data is going to be handled in a trustworthy manner. And then another point, which when I mentioned my EMS background, another point is all of us during certain days and certain times in our lives, we may be completely rational about things. But when you're facing a significant medical problem, when you're at the end of your life due to aging or due to a medical condition, when you're dealing with granting consent for a child or a teenager, you're under a lot of pressure, you're under a lot of stress, and you know, your whole cognitive function kind of narrows down to something about this big, and it's difficult to understand. So I think there's an argument to be made that some of these consent decisions really need to have a trusted human being involved to help somebody through the process. In some cases, they need to have material that they can take home, study, talk over with their family, et cetera, before they make a decision. So the efficiency expert people like myself don't always get our way. And sometimes we have to slow down the process a little bit to help people with the trust issue and with really understanding the consequences of their consent. Thank you.
Thanks so much, Ed. And Tanisha, we have a little more time than anticipated, so please feel free to use those couple extra minutes if you need to.
Yes. So as I was listening to everyone, I was centering myself as a community member or a patient, a consumer, and I think some of the challenges that I encounter when it comes to e-consents and things being efficient and effective. Oftentimes in our line of work, we're dealing with people, as Ed was expressing, who are in vulnerable situations. Someone said it's difficult to hear me. How about now? Is it better? Okay. We're dealing with folks with really difficult situations. And I think to some extent, you know, when it's talking about clicking a box or doing an e-consent, we're talking about accessibility and understanding. And I think for me, personally, what I encounter is that people want to be informed. And I think it's important to note that when it comes to trust, it's not just about having a stamp of seal of, you know, this particular network or this particular technology has these set of standards, but I think it's also a level of who's making money off of my data, who's sharing my data. And I see myself as, when we're talking about equity, we're talking about sharing the expense that's being compensated for people having access to my data. I know that might be a little bit more revolutionary, but I'm just thinking in terms of a lot of this is coming across as transactional and to a patient that doesn't feel well. And then I would also say that I'm no expert, but I think, you know, being able to explain terminology in a way that is accessible and comprehension, and as things are being updated, I think if my data set is in your database across multiple technology platforms, I should be informed of those changes and who is having access to that. So I think trust is something that is continual. It's a reciprocity aspect, and I think it's important that, you know, trust is not just a one-time thing with a set of standards, because as we know, standards change, and, you know, technology doesn't replace humanity. So that's all I have to offer.
Thank you so much, Tanisha. And in your work at San Diego 211, you work with diverse and vulnerable populations. And Ed, as you mentioned earlier in your introduction, that you have a second career working with people at vulnerable times in their lives as a first responder. Would you both mind sharing an experience that you think may help us to better understand the types of situations we need to keep in mind as we're working on e-consent solutions that work for everyone?
Sure.
Tanisha, go ahead.
Sure, yes. I would say first thing that comes to top of mind is, you know, we have an opt-in model, and essentially right now, you know, once you opt in, and you can also revoke your consent. But one of the features that we have within our platform is, you know, being able to assign yourself as a care team coordinator. So let's say hypothetically, I am, you know, I've been admitted to the hospital. I came in through emergency services, and my housing navigator is assigned to my care team, as well as, you know, my food distributor, as well as, you know, my health practitioner or what have you. And they get an alert through our system letting them know that I've been admitted. The way that we see that is that this is a way to provide proactive care. But let's say that person, you know, at the time that they initially opted in or authorized to share their data information with us, completely forgot about that. And then now I, as a housing navigator, upon their discharge, I'm, you know, reaching out to them saying, hey, you know, do you need help? Now, we think that that's proactive care, but they may be saying, wait a minute, why are you following me? What's going on here? And so initially, as Nancy was expressing, the trust in getting that e-consent, it has now kind of created a little bit of concern on the patient's part. And that's where I think, like, reminding folks, and just like, even if it's an email or text message saying, hey, do you still want to be a part of this system? But that probably presents a challenge for us in keeping, you know, those client records robust that we all find beneficial. Ed, what are your thoughts? Because I know you did a lot of time as a first responder. Have you ever encountered that?
Yeah. Yes, you know, I think there's a lot of different factors, and you know, when we were preparing for this, Tanisha and I got a chance to chat a little bit over the weekend, and it caused me to think about some of my experiences. And I think what I want to just share is a couple of thoughts on consent overall, not only consent to electronic information, but consent in general, which requires some different factors. And I'm not going to talk about the legal aspects of it, but when you're consenting to something, you have to have the capacity to make a decision in order for that decision to really be essentially informed consent. And you got to be able to digest what you're being told, what you're being asked to commit to. So I was just thinking of a few cases where somebody had to make a decision and maybe there was a little bit difficult to make the decision. One evening, and by the way, I did this for 14 years. I'm retired from this aspect of my career right now. But one evening we got called to a woman's cabin here in the mountains of Colorado, and she'd had a nosebleed on and off for a week and couldn't get it stopped. So we were called, we responded and talked to her. And there's sort of three things you do as a first responder when you show up someplace. First is the scene safe. And that means, you know, are you in danger? Is the house on fire? Is somebody hiding in the closet with a gun? You know, you got to make sure the scene is safe. And then the second thing is to introduce yourself. You know, hello, Trudy, my name is Ed. I'm a firefighter. I live over on the other side of the mountain. And, you know, what's going on? I understand you've had a nosebleed here for a long time. And, you know, tell me what's happening. And so establish a trust relationship, a dialogue with the patient. And then the third thing is, now that the patient knows who I am and why I'm there, get consent to do what you have to do. In this case, you need to do an exam, usually a head to toe type of exam, to just see what really is going on. Why did this person have a nosebleed? What's the problem? And so, Trudy, is it okay if I do an exam? I'm going to have to touch you all over, but we're going to do that. So yes, Trudy agrees to that. Now, the situation is, well, Trudy really needs to go to the hospital. She's failing. This is a chronic situation. We've got to get her to the hospital. Trudy, may I take you to the hospital? You know, you need to have that type of advanced care. And no, you may not take me to the hospital. Well, Trudy, you need to go to the hospital. Why? Well, after a discussion, you find out that Trudy's worried about the bill for the ambulance, the bill for going to the hospital. And she's got, you know, a child there. The child has little kids, and she's worried that the money is going to go to her medical care instead of taking care of the children. So that's one reason we have difficulty sometimes getting consent. And one other situation that I thought of is a situation where we had a grandma and grandpa riding their Harley across country, and they crashed off of a highway, and we were called to the scene. And so we arrive, I'm talking to the grandpa, and he's pretty beat up. He's in a bad situation, but no, stay away from me. Don't touch me. Stay away. I want you to take care of my wife. Well, sir, we need to really examine you. We need to find out what's going on. We need to take care of you. No, take care of my wife. Well, it turned out that was not possible because his wife had died in the collision. And so we said, well, you know, don't worry about that right now. Let's take care of you. And we've got other people taking care of her. Let's take care of you and take you to the hospital, and then we'll take care of her separately. So there's a reason for not getting consent. And the reason was, as we know, he was more worried about his loved ones than himself. And so one final little scenario here, just to share my lived experience. This time I was down in Colorado Springs. I'm usually farther north than that. And I was responding to a situation with a homeless woman that was acting confused. She'd been shoplifting. She was essentially a vagrant, meaning she didn't, you know, have any place to live. She was with a bunch of other folks that were friends of hers, but, you know, this woman was clearly having a difficult time. Fortunately, we had law enforcement, paramedic, and a mental health counselor with us. And so we talked with her, and, we figured out pretty quickly that she really didn't have the capacity to make a decision about where she was going to get her care. It sort of ultimately ended up that she had two choices. She was either going to go to jail or she was going to go to the emergency department. And she really was not in a situation to be able to figure that out. So fortunately, we were able to call into headquarters, tap into the health information exchange, and find out her medical history was that she was had been hospitalized multiple times up in the Denver area. We wouldn't have known that because we kind of only had local access to law enforcement type data down in the Colorado Springs area. We found out that she'd been hospitalized and that every time she'd been taken to the ER, medicated, stabilized, and was able to be discharged. So fortunately, we took that as advice to be able to do the same with her down there. And, ultimately she was able to be discharged. Now I'm just kind of went through these cases only to say that consent is not a simple matter. Sometimes people are competent to make a decision, but yet due to extenuating circumstances, they may make what we think is the wrong decision. Other times they just don't have the capacity to make the right decision. So anyway, Dr. Mason, I just wanted to share some of those experiences because that's what we're dealing with here in the whole spectrum of life and consent. Thank you.
Ed, Tanisha, thank you so much for sharing those lived experiences. And, I just wanted to take a step back and mention that, that this workshop is really a discovery workshop. And I really appreciate all of you sharing information to help present the challenges that are out in the real world, that we have to develop solutions for all of these circumstances, and then layer on top of that electronic solutions for these consent challenges. So it's very helpful for us to hear about some of the actual real world scenarios that we need to be considering. And so at this point, I'll ask our fellow panelists to reflect on these shared experiences that Ed and Tanisha have shared. And I'll start with you, Carol, if you won't mind.
Happy to. And I'll try to speak up. I heard that I might be a tad quiet.
Yeah, I'm not sure. The audio does seem a little bit lower.
I don't know. It was mixed on the test this morning. In any case, the thing that I really heard both from Ed and Tanisha was that there are cultural issues around consent. There is often confusion about what consent means, and there's technical limitations to managing, tracking, and being really truly informed that there is a consent form signed for any type of data sharing or use. And I think that the examples were excellent. We've heard through our consulting years many others, sometimes paternalistic opinions of providers, mental health providers, particularly in some survey work that we've done, really said we'll never share our patients' mental health information. But when you drill down and you say, if they ask you to, will you? If they feel that that would be helpful for their primary care provider to have a better understanding, and that level of understanding throughout the nuanced levels of healthcare and social services. And there's been quite a few comments about, that we're really talking about healthcare right now. And I want to address that. Some of the comments that I've been reading during the presentations have really been wonderful. I mean, just so much great information shared, and also some confusion, I think, about what we're really trying to say with a consent form. And the all or nothing, all in or opt out, opt in kind of discussions that we've had for the last decade and a half on consent management, I think, are really to blame for that. If you think about the nuanced information that anyone who has vulnerability in terms of their health or social needs has to deal with, they may receive services from 5 or 6 different state or county local agencies, in addition to the providers that they might see for chronic disease and mental health issues and possibly substance use issues as well. And so when we talk about the granularity or the ability to make choice, from my perspective, and we saw a lot of consent forms from the whole person care demonstrations in California that required individuals to sign a form, a single form, that all of their data was going to be shared across every county agency. Anyone who had any touch point with that system would be allowed to use or share their data. That just felt like an equity issue to me, for sure. And when I talk about consent being an equity issue, that's really what I'm talking about, is allowing people to say, I understand why I need to share my financial information for eligibility for a program, but that person does not necessarily need to know my reproductive health background, or or the fact that maybe I had a family member that had involvement with the justice system at some point, because that is how easily data is linked, and particularly in these whole person care programs, which I'm a complete and total supporter of. So when you think about granularity and you think about consent forms, and this is the way we have approached it with our product ShareApprove, is to to step back and say, let's use a form for each consent need if necessary. Why just have a single form for sharing data? And so then if you need to say, I'm going to ask for the sharing of mental health data, that could be a single form. It doesn't need to have a list of 10 items that one wouldn't be checked, so therefore might expose somebody's personal information. And this also reduces the friction that you see between, legal, the lawyers, I say, sitting around the room saying, well, I like my form, and then, but we really like ours. And so if the sender of data or the user of data has consent for that purpose, then legally, you can say that can be, that fits within the realms of Hipaa and specially protected data. So I don't want to dominate, and I want to give Nancy a chance to respond, but I do think that the issue is so confusing to many people, has so much culture around it, cultural aspects of this in history, and we all are entering into the discussion of what is in the box, not what can be. And I really want to try to shift that discussion to what can be, because the new standards and fire consent standards have really opened up the ability. Data tagging is maybe imperfect right now, but getting really better and better, and has all the chance in the world to really be meaningful. And what we really need is to be serious as a country about protecting privacy. And I saw that in the comments as well. So I'm going to say here. Nancy, I'm going to take it from here, okay?
Thank you, Carol. Well, I have to say it's tough coming out behind all of my other fellow panelists on this one. So, I certainly hear all the points that Ed and Tanisha have made, and boy, I wished I had answers to all of those use cases. I know some of the deep dives we have done on many use cases that do exist, really start, having to scratch your head pretty quickly on how we're going to solve all those. I don't know what those answers are. I certainly agree, what you said too, and in terms about this opt-in, opt-out versus granular sharing, I think it's totally necessary to be at that level. I thought I would also share a little bit of my personal story. So I had a sister that died at the age of 59. And at the time, her providers did not have access to her records to make informed decisions. I'm convinced that had they been available, she'd be alive today. So we simply need to make it easier and provide patients for ways to share their data. We know this challenge is well known. It's not a surprise. We've known it for a long time, but we need to have a method to have patient data travel with that patient wherever they receive care. And instead of having data stuck in multiple siloed repositories, we have that technology now, and these systems can be automated. And not only would this help all patients, it would also help to reduce the burden of exchanging data and reduce healthcare costs. I do think that this is going to involve a big paradigm shift. I think we need, it's very easy to think of consent in the ways that we currently think of our healthcare exchange systems today. I think we're ready to turn it on its nose and kind of look at it very differently in order to really start to solve these problems. Thank you.
Thanks so much, Nancy. And I also had a question. I wanted to follow up. Earlier, you mentioned about the importance of reducing burden as a part of the consent process, and wanted to hear either your thoughts on that, or because once we get into more granular consent, we have to think about the patient as well as the provider in terms of how to be the most create the most efficient workflow and technology solution from that perspective.
Yeah, a lot of people think of our names as patient-centric solutions. It's only thinking about the patient side, but we actually are thinking about both the patient and the provider side. It's a real challenge for providers, to share that data. They have obligations to protect it, which, of course, that's very important, but they also have these obligations to share it, and sometimes they're at odds with each other. It's a lot of work to get data ready and to get it off to the correct destination and know that that's going to happen. And that's why it really needs to be automated. So, we're really interested in that aspect. So not only from the patient side. And I guess I can go on to that a little bit more. I don't know how much detail you want me to cover here.
If I could add that, and we do have Mohammed Jafari, the CTO of Modado Health, speaking in a session later, who can go into more details from the technical standpoint than I'm able to. But I would say that approaching this from a user-centric point of view, both on the patient side, provider organization side, and when I say that, I mean those with the most sophisticated EHR systems and those with a spreadsheet that they may be, managing on a laptop. We need to think about all of those experiences, and because, as I said, the information that makes us healthy is way beyond the healthcare we receive, and so and with value-based payment and global budgets now in healthcare really advancing that whole person care model, the coordinated care between housing services and transportation providers and food assistance programs, along with primary care and mental health professionals. That consent management has to be computable, and I saw that, but it also has to be easy to use, and that easy to use from a provider perspective as well as an individual's perspective. We thought about this as kind of the Michael Porter Harvard Business model of third order fit, where you combine different kinds of processes into technology so that, if I'm got a consent request, I may not have another one for 6 months or a year. I might delete that app if I don't have another purpose for it. But that's why we've built our solution to have other digital forms available and to have more functionality. And with FHIR APIs, the functionality that you might be able to build with, and we might add to a patient engagement solution, for example. would just be so useful. And that kind of plug and play is here. It's here with FHIR. It's so exciting, and we just need to take some time to invest in this and
Yes.
and test it out.
Thanks, Carol. I know we're running short on time. I wanted to make sure that Tanisha and Ed had at least 30 seconds each for any final thoughts and comments to share.
Nisha.
As I was listening to my fellow panelists, I think, and I'm no expert when it comes to all of the technology stuff, but that's what the discovery part of this is. But I would just like to, what's landing on me is that technology is looking to solve complicated, aspects of, getting information and things of that nature, but human beings are complex. And so I think in some instances, it might be advantageous to slow down a little bit and not, like in the modern world, we're always looking for action, and how we can be efficient and effective, but we're dealing with people. And I just like to center myself as a patient, even if I've consented to something or authorized or opted in, when I'm meeting with my medical practitioners, I don't want them just, looking at the information and then making assumptions. I still want a conversation. And I still want to be an agent in my care. And so I just think it's really important that I love technology, but technology does not replace our shared humanity. And that's all I have to say. Thank you.
Great points. Thanks, Tanisha and Ed.
Well, it's a little hard to follow that comment, but I would only just say what Tanisha said, and that is that we need to consider the patient and the provider and how they work together, and making sure that everybody has the information that they need in order to make the best decision for the patient. So that's all I have. Thank you, Dr. Mason. Thanks for moderating, by the way.
Absolutely happy to. I want to thank you all for this outstanding panel. It's given food for thought for the rest of the day, and a tremendous amount of valuable information, challenges, and opportunities. And at this point, I'll pass it over to Tricia Lee.
Thank you so much, Tom, Carol, Nancy, Ed, and Tanisha. And of course, thank you to all of our attendees who are just actively engaged in the chat. This is the time where we all get to participate. We are going to transition now into our breakout rooms. Our breakout rooms are going to cover 5 different life stages: birth, maternal health, childhood, adolescence, adulthood, and end of life. And a lot of what I heard or saw in the chat kind of sanctioned around this is complicated, this is hard. How do we have systems in place? How do we have procedures in place to help make these tools and standards work the way we would like and intend? And we're going to talk a lot about that in our breakout rooms. We are going to give you 40 minutes. So from the time we break, we will run the clock 40 minutes later. That means we'll probably end up taking maybe 5 or so minutes out of our break that comes afterwards, but that's okay because we really need this time. And so what you can expect is that you will be entering the breakout rooms on mute. You will be receiving instructions from your 2-room facilitators, who will then work you through a series of questions and thinking through different personas. We're going to look at sharing EHI, all or a portion of it, and we're going to think about how do we capture consent decisions, manage consent decisions. To do that, not just with HIPAA covered entities, so provider to provider, but also with non-HIPAA covered entities. So depending on what room you're in, you might have scenarios where you're answering questions around sharing information or consenting to do that with an educational institution or with a court, etc. So again, we want you to bring your best collective thinking to these breakout sessions. I want to remind everyone that while there are some real true points to be made about the policy and regulatory landscape, we really want these breakout sessions to hone in on what is possible. What are the approaches? What are the workflows? What can we make note of to operationally make these things happen?